It's good to have you come to the afternoon, and welcome to the speakers as well. So the title of this afternoon is Personality Disorder Controversies, Evidence and What Do We Do? And I think linked to that, some points I want to make, and that is in terms of controversies, we thought of the title. Oh. Is this better? Is this better? Okay, so let's just start again. So welcome to the afternoon. The title of the afternoon is Personality Disorder Controversies, Evidence and What Do We Do? And linked to that is, in terms of controversies, I think the point is that there's actually a lot that we don't know about it, hence the controversies. And in terms of, there are lots of different viewpoints as well that we have about the subject matter. And in terms of evidence, while it's building, there's still a lot that we don't know. And therefore, it's what do we do? What do we do when we don't know? I think the reason why I'm just putting this up front is that it's sort of how we approach the afternoon, really, where in fact, probably a lot of what we think about personality disorder is linked to our own feelings about it, rather than real knowledge about it. So I think the invitation when we thought about the afternoon, and when Hugh and I thought about it, is hopefully we're going to kick off or generate a fresh thought. But the invitation is to have sort of live thinking, but not necessarily polemic, because I think often the subject matter invites very strong views. So I think it's really an invitation to express the views, but in a way which is within the frame of us being able to think. So in terms of so we'll start off with Richard, and I'll briefly introduce Richard. Just to say that in terms of the afternoon, Scott is running late, and so we'll move up the introduction to how one thinks about classification to the second slot, and then continue mainly as planned. I think what we're trying to do is to stick to time. So that means that when we restart, we'll restart sharp. So if you want to get a sense of what the debate is, please come back on time. So just to introduce Richard. So, hi, Scott. Scott, you're very welcome. It's good to have you. Good to have you join us. To introduce Richard, Richard's a general practitioner in Plymouth. He works as part of the outreach team in probation and is a GP with a special interest in mental health in the Icebreak service for young people. Richard's also a professor in primary care research at the University of Plymouth and leads the community and primary care research group. His specific areas of expertise and interest include primary care mental health systems, shared care for long-term mental illness, treatment of depression, and offender health care. Richard also has experience of service development, policy, and teaching. So, Richard.
Shall I use this? Yeah, hello. Thank you very much, Tennyson. Yeah, it's a pleasure to be here. I went down to Plymouth in about 2001, 2002, and but before that, I was trained in East London and worked in Lewisham, setting up a practice there. So I have some understanding of the kind of London situation as well, and it was kind of a really interesting move getting down there, that's for sure. So I'm going to try and overcome my imposter syndrome of being a GP amongst psychiatrists, and as Tennyson suggests, I think it's going to be really helpful to be really kind of in the moment of kind of responding to our kind of impulses to disagree and our kind of our abilities to think new things. Not that I don't think there's going to be anything very much surprising, but who knows? So we're going to, I'm just going to give you a quick, brief overview of my training history in understanding mental health. I think we all have a kind of a learning over time, don't we? And it changes, and we all develop our personal practices. And then we have the system around us that tells us how we should be thinking and how we should be working. And often we keep our personal thoughts quite private. We have to interact with our teams and be on message to various things. And I've been very lucky to have lots of support in thinking a little differently and changing my mind about things. And then we'll kind of move on to how that developed into the three lens model that we've developed in Plymouth, and think about that in itself and in practice and in systems. So yeah, I was brought up with the Defeat Depression campaign after my training. You know, everyone was going to diagnose depression, treat it, and everyone's going to be better. And there were great papers from Scandinavia about how suicide rates were reduced as a result of the amazing progress they'd made. But I kind of focused in my practice on severe mental illness, and did a PhD in shared care, and then moved down to Plymouth in 2002. Shortly after that, joined the Icebreak team as a GP. There was no doctors in the team. There was no psychologists in the team. It was a social intervention for personality disorder that was set up as one of the pilots in 2004. There were 20 around the country. This was the only one for young people. We had a psychologist overseeing it, but he was intent on kind of there not being much psychology or psychiatry in the team. So that's fascinating. I took on various commissioning roles, and also we, in our practice, developed an outreach service for homeless, and I was working in the kind of probation arm of that, and have done since for 15 years, alongside research into various complex needs, including those of prison leavers. And we ran I've run several large program grants where we've developed a kind of shared understanding, person-centered biopsychosocial approach to support individuals with dementia, individuals with psychosis, and male prison leavers. So general practice in Stonehouse. We're in a tiny practice in a very deprived area, which is becoming amazingly multi-ethnic. It's a fantastic combination of a tiny minority of yacht owners and a lot of people who are homeless, a steady increase of people coming to work from abroad, living in our area, and the main population of who've lived in families there for many years in substandard housing, with very low rates of employment. As a part of that, so what we see is the kind of normal stuff you see in general practice, and it's extremely complicated and disturbing at times. We have people you know, the crossover between mental health and physical health, the growth in fibromyalgia as a thing, which is, I think, really pertinent to the brain-body divide and how we think about mental health problems. In probation, I've done a clinic for 15 years in probation, and I get referred people by the probation officers who don't have a GP, can't get into mental health services. And I'm sure you, as general psychiatrist, you can imagine the amazing mix of people I see, who, you know, have, you know, all the labels under the sun, or none when they arrive. Often none, because many have not had any care at all, and are just disclosing traumas of 20 years ago for the first time. Others have been through the mill, as it were. So working in Icebreak has been my greatest education. So Icebreak's a team for young people with personality disorder, emerging personality disorder. It's a non-diagnostic service, and I was brought in, I think, to try and make sure there were no psychiatrists in the team. And luckily, I was supervised by Dr. Joss Dawes, which was a fantastic job in supporting me think about these people. I was being asked suddenly to adjudicate who should be in the team, had they got the diagnosis. And so I had to suddenly go back to the basics of you know, mental state exam and the diagnostic manuals, and thinking, my God, what I'm really out of my depth here. And you know, you get these kind of things going on. You're seeing people who, and this is a kind of, you know, clusters of BPD, bipolar, you know, PTSD, mood disorder. It hasn't got psychosis in there, hasn't got autism in there. It's far more complicated than this, of course. And I soon realized that I could make 10 diagnoses, or sometimes none. And I had people who had symptoms across 5 or 6 or 10 diagnostic groups, but didn't meet the criteria for any. And so we had to do some deep thinking about what to do. And there were kind of 3 key steps in the Icebreak work that we started to develop. So, you know, doing a mental state exam, starting to think, okay, what's going to be helpful for the person I'm talking to when I'm doing this archaic thing that I've dug out of my training. And then, because the team was essentially more of psychosocial thinking, what's the causal model for each individual is really crucial. You know, you've all been trained in formulation, and that's fantastic. But as I started reading, I realized that there might be some, you know, there was deep neuroscience behind this array of symptoms that I was experiencing as a clinician. What on earth was it like for the individual, or the many individuals? So we started to you know, just develop a model of how to make sense of this. And so I wanted to try and, you know, in my fantasy world, to democratize the mental state examination. And so just try and, instead of it being something done to, how can we talk through this? And so thinking of conscious experience, thoughts, emotions, and perceptions, I realized the mental state exam was actually really good. It was very helpful for helping think through those different aspects and share that with individuals. So we did lots of drawing with people and working out what's going on. But of course, in the background, there was the genes and the epigenetics and the various traumas to the brain body that appeared over years to have caused these problems. But we were a strengths-based organization, so we had to have to start thinking about capabilities and assets the individual have as well. What were their mental and physical and social relationship assets, as well as behaviors? What positive things were they doing, as well as the negatives? In parallel, this was something that was kind of published as in the BJGP as a way of thinking about depression. And so this is again, I'm sure everyone's done similar things. You do drawings, you work with people to try and think, what's gone on in the past. Where's the, how does it relate to bodily symptoms? The thinking and emotions and perception needs to be in the middle, and then actions and behavior. And this one doesn't have the strengths-based issue built in. And then what could we learn from neuroscience? And because I'm a kind of critical realist, which means I'm not a constructivist, but I'm not a kind of a normal kind of realist which is what a lot of science is based on. So I was really interested in the layers and levels of interactions and trying to work out what's going on in the brain, but also what's going on in society. But at a kind of brain level, we started developing explanations with individuals, and I found that people found it incredibly reassuring and helpful to have a kind of neuroscience explanation of the causes, the fact that the brain was perhaps not broken but out of balance. And I kind of remembered this word of allostasis somewhere from my training, and realized that to me that's what was going on. There was a failure of allostasis, failure of the brain body to maintain its normal functioning that felt good. And it's not that it's broken, because there's no bit in the brain that we can look in under an image and see, but it's certainly out of balance, and there's something going on deep in the brain that's giving people experiences that are at their conscious level that are really really tough to deal with. So how do we explain emotional reactivities? There's lots of science behind that now, which is fantastic. How do we explain perceptual disturbances? And I was really influenced by Richard Bentle and his kind of thinking on hallucinations and his explanation of that, and how effectively all of our sensory experience is a virtual reality that our brains are creating for us. It's not how it seems. It's not that we look out and see things. Instead, we are receiving information and creating an image of what looks like this lecture theatre, and it's congruent with what is actually there. And that's how we find our way around the world. And a rhinoceros has the same kind of thing, but it's a sea of smells. That's the main virtual reality that the rhinoceros creates. Whereas, and the patient, they love it when we talk about that, and how, but when that goes wrong, when you take magic mushrooms, when you have a high fever, when you've got disturbances in the brain over time, then that isn't working as well as it should, and you can have these awful experiences of flashbacks, dissociations, and hallucinations. And helping people explain about thinking, and just having a few basic models, like the theory of mind. I thought theory of mind is such an important thing. We were never taught it at medical school. Crazy. But it's so important to understand that ability of humans to take in what's going on in your own mind and imagine what might be going on in someone else's. And if there's a failure in that, then that can be effectively seen as a kind of like a delusion, where you're fixed view of what someone else is thinking and doing, or you can't do it at all. And then, of course, brain plasticity as a way of generating hope and identifying things that people have actually changed over time in the last months, and identifying that as a change in the brain that they can see has happened for them. So how do we understand what's going on to help individuals understand themselves? So we've got all of these genetic, neurotransmitter, inflammation, all of this stuff is being investigated. But for me, the psychoimmune and neuroendocrine failure of allostasis is what makes sense for mental health problems and a lot of physical health problems more generally. But so should we see personality disorder as a psychoimmune and neuroendocrine phenomena mediated by societal culture? So obviously everyone knows about adverse childhood events and the impact on virtually every health condition. And we've now got some pretty good science emerging around how that affects the brain. And so some great studies in New Zealand, Dunedin, that are showing the change in microglia and a whole load of other things. And it's contested, but I think there's something there. There's got to be something there. How else would trauma have an impact on the brain and cause such terrifying disturbances for people? And then COVID kind of like made me think again about viruses, and I remembered those graphs in the ancient epidemiology of schizophrenia and how recent Kotsiri has done a great new review of how viruses impact on the brain and schizophrenia. Why wouldn't they also be impacting the brain to cause some of the disturbances that we see in so-called personality disorder? And you know, the neuroscience models, we've got the RDoC process that's been developed mainly in the States, and the NIH in the States, they gave up on diagnosis because the drug companies knew that it was a problem. And so they went down this route, and it's been tricky, and they haven't been as successful as they would have liked, but they've been intent on looking at brain circuits and all of this stuff. So my model in my mind as a critical realist is one of you know, layers of reality that interact with each other. So at the top, we've got socio-cultural structure, then we've got the social, the interpersonal, and then we've got the intrapersonal consciousness, and that's where most of the symptoms lie. And then you've got the brain as part of the body, the physiology, and then the intracellular, genetic, etc., etc. So over time, you get genetic code, you get the development of consciousness, maternal roles, infant interactions, support the development of healthy consciousness, and healthy communication, a healthy sense of self and the outside world, with good nutrition, environment, and pathogens, and a supportive peer group and culture. And that's what we strive for. But for some people, we have, you know, abnormal periods, childhood sexual trauma, unequal gender and power relationships causing that at the social level. And that's having an impact through dysregulated HPA access to a dysregulated immune and inflammatory response. And that in some way relates to these cognitions of shame and unpleasant emotional reactivity, withdrawal from society, medication seeking, verbal aggression. These are cultural things that develop in communities, and a fluctuating whole body pain, feelings of exhaustion, a sense of a fractured shell. Are we up for time?
No, you'll get another 3 or 4 minutes.
Yeah,
right.
Yeah. So what about treatments? We do have a problem with treatments. So I just love this slide. This is the childhood leukemia slide, just something on numbers needed to treat. It's really important. I'm trying to teach medical students what's great medicine and what's really not so good medicine. And in the 1950s, nearly every child died of leukemia. Now we have 95% success, and the number needed to treat in leukemia is 1.33. That's fantastic, isn't it? We have great medicine. We just need to get every person with leukemia into the system so we can treat them early and save lives. It's not quite the same story for mental health, and so most mental health treatments which work a bit have number needed to treat are 7 to 12. This means a difference of 0.125 in recovery rates. So it's not really what I would call great medicine. And how do we live with that as clinicians who've been trained to be fixers? So back to diagnosis. Recently, well, a year and a bit ago, I had a stand-up public argument with one of our local psychiatrists about whether the new community mental health framework team for personality disorder should be called a team for personality disorder, or should it be called something else? It wasn't really very helpful to have that kind of public disagreement, not helpful for fellow clinicians, and certainly not really helpful for patients in the community. So we thought about what are the ways forward. Building basic blocks are all, the building blocks are all there, great communication, etc., etc., and developed the the Plymouth 3 lens model by getting together as clinician leaders and really supported by the voluntary sector and some patient leaders as well, to develop a trauma-informed, strengths-based, diagnosis-aligned approach to mental health. It's really not that different from what you have learned in your formulation work, or what is taught in the college now, I think. It recognizes the importance of past trauma, adversity, and loss. The diagnostic tradition and the understanding of neuroscience is helpful to a point, and identifying personal, relational, and community strengths and using them is critical. And a kind of model for practice might be slightly different, but again, it's the formulation that you've learned alongside the diagnosis work. It's engagement and trust building and narrative, developing a shared understanding. For that individual, I think that for every individual we see, we should be thinking what is going on for them, and what is the plan that we need to put in place to disrupt a difficult causal set of loops that are problematic, that are operating at social and psychological and brain-body levels. So we've got 4 problems for the system: an imprecise, unreliable diagnostic model, low effect sizes with very few effective treatments, identification encouraged, winning the stigma game. We've done that really well, but it's although that's a bit mixed for EUPD, and then politicians, media, and professional bodies who don't like to acknowledge the 3 above and keep encouraging more and more people into the system. But we're not like an adult leukemia system. We're not like an HIV system. We don't have precision to get the right people in and then to treat them and fix them, send them away. So this leads to an increasing proportions of people seeing themselves as having PD, with increasing proportions on medication. The quetiapine, I would like to show you the quetiapine prescribing curve over the last 10 years has been extraordinary. So the 3 lens response to a system needs a personal mental health care journey. We need to think about individuals on their journey over time. So people are going in and out of the system. And I think this map that we developed from the community mental health framework we've been doing, and we were part of the evaluation in East London. So hello, anyone we had contact with there. So if we can have a system where we've got initial access to services, engagement, and shared decision-making and brief support, some people having reduced support quite quickly, then but a few with those with the most needs staying in, we can create a balanced system. So we think about individual journeys over time, but also the system as a whole. So we can do it. We're in charge. We've developed the rules. We have created this. We can uncreate the mess of huge workload and enormous waste of resources being put into the wrong things and the wrong people being in the system. We can do this. So within the Icebreak model, just sort of as a, I love this team. I'm so proud of what we've done. We need to write it up better, but the key features are diagnosis aligned with looking at what we've talked about, but the components in the team are really flexible, flexibly deployed, one-to-one engagement work with kind of an MBT and psychodynamic informed approach. We put in the neuroscience explanations. The team are taking this on, and they don't need me anymore. It's fantastic. And the shared understanding of traumas and strengths, addressing social adversity. The first thing we do is support people in whatever they need at that moment, and then getting them into groups slowly and gradually. Most of them do get into groups for DBT and emotional awareness and planning endings. I'm not going to talk about the frameworks. We've got no time. We've run out of time. Actually, no, I am. So we've got the gap. So we can't not talk about the gap that the community mental health framework was supposed to set up. So we had the green 3 years ago, and now we've got the blue as well. But it's really complicated because you've got liaison, specialist teams, CMHT, general practice, and IAPS, and the big gap between in the middle where no one had anything. And then not only it's not just one new team, it's about 4 core teams and several other teams all working together. It is so messy out there, and every every community is developing it differently and using different words for different things. So we've got community connectors doing social prescribing type work, peer support, amazing examples of some peer support teams where they'll take anyone. They don't hold risk. They know they can't, because how can you hold someone's risk? So they understand that risk is not something you hold. It's sort of like nonsense. They know that individuals have enormous skills to manage their own risk, and it's their risk and it's not. So they don't take that responsibility. So it's so interesting. You talk to them. But whereas the psychological therapies team are terrified, all of these weird and wonderful groups and mix of people coming in, and they've got all of their secondary care learned procedures that really don't work in this situation. Supporting individuals with complex needs. So I just want to end on this point. It's a project we're just starting up and is thinking about those people in the criminal justice system and substance misuse who can't get into specialist mental health teams because they've got, you know, they're being excluded, but they couldn't turn up anyway. But they've got loads of workers. They've got housing workers, substance misuse workers, criminal justice team workers. So we're doing a support where we're using the 3-lens model, mental health worker to supervise and support those workers who are doing great mental health work already, to use a 3-lens model to support the most in need.
Thank you so much. I'm sorry for stepping forward a little soon there. The structure of the afternoon, for those that arrived late, we have 3 speakers, then there will be a chance for 10 or 15 minutes of questions for all 3 of them and a bit of discussion, a break for coffee, and then the sort of debate, in inverted commas, to finish the afternoon. We'll move on to our second speaker, but hold on to any thoughts. There's lots of interesting thinking in that first talk already, so thank you so much. So our second speaker, you're right to come up, yeah. Yeah, so both our speakers have come from far and wide. They've negotiated trains across England, which is probably the significant achievement. So Scott is an academic psychiatrist. I'll do the intro. Sure. Is an academic psychiatrist and professor of mental health at the University of Sheffield, where he leads the mental health research unit. Worked as an honorary NHS consultant psychiatrist for almost 30 years in London, the West Midlands and South Yorkshire, and currently works in North Sheffield CMHT. Co-lead for the mental health and multi-morbidity theme, Yorkshire and Humber ARC. Research interests including inequalities in experiences and outcomes of mental health care, including coercion, restriction, and public mental health.
The slides there.
Yeah, let's find out. I might need some technical support with finding the slides, unless you're aware, Tennyson. That's Tennyson.
Finding slides.
The email to Sean. Okay, give us a moment. Sorry, everyone. Tennyson's just going to check with Charmin.
That's right. I'm going to cut it up. It hasn't been changed. Go back to where they were. I'm fine. You're not going to how she was going to get there again. So I wasn't sure how she was going to get them out there to any
Just switch to this one, but we'll try and find that.
Okay, well, okay.
Okay, sorry about that, everyone. We're going to switch the order. So Tennyson, who can introduce himself, is going to speak first, and then we're going to do our best to get your slides, and we'll come back to your talk. Okay, over to you, Tennyson.
Thanks.
So given the time, the objective of this part of the afternoon is just to give you some sense, give you some knowledge about what the thinking is about the use of ICD-11 personality disorder, with the hope of how you then think about approaching it. Clearly, in the amount of time we have, it's not going to be a skills workshop in terms of how you actually do it. But hopefully just the initial knowledge of it will give you some sense of how, what WHO is recommending in terms of how we use it. So I'll be speaking in terms of this is what WHO says, and I'll try to make clear if I'm making more of a sort of personal comment on it, because it really is about trying to sort of teach us about what WHO are aiming to do. So these are general points about ICD-11. And when the task groups worked on ICD-11, they really emphasized that let's try to do it better this time in terms of this iteration of ICD and to make it more useful to clinicians. So what all of the task groups were asked to do was to really focus on the clinical features, to make it of practical use to clinicians. Therefore, for example, the biasing of the guidelines towards clinical judgment. It's more important what the clinical judgment of the clinician is rather than counting the number of symptoms, for example. So rather than sort of arbitrary cut-off points. In other words, it was meant to be more aligned to the way we as clinicians actually make diagnoses. And what's been, I suppose, affirming for ICD-11 is that there have been studies that have found that clinicians find ICD-11 of greater clinical use and with comparable reliability in terms of use of it compared to, for example, research instruments. So, have we now got Scott's?
Scott's. I'm going to upload it from the outside. Yeah.
Thanks so much. So the other thing in favor of ICD-11 is that from the, this is around personality disorder now, from the available evidence, because as you'll see, ICD-11 PD emphasizes our thinking as clinicians about severity. So that's quite useful because there is evidence that severity is what determines, as we would think as clinicians, determines both prognosis and again, practically, as psychiatrists or as GPs, we think, well, with this level of severity, this is probably the level of care required. There's also some evidence for the domains that are proposed. So in terms of timetable, so this is what I could find online, that NHS England says our assumption is that it will be in use before April 2026. So by thinking about it now, we are ahead of the curve. Although WHO was saying it should be in place by, we should be using it by 2022. So this is probably the main slide that I want you to get a sense of. In terms of ICD-11's approach to personality disorder, it says there's 3 steps. First step is PD present, yes or no. It's the first step. Second, what's the level of severity? And the third is what's the flavor of the personality disorder? In other words, what's the predominant trait? And then there was a lot of politicking within the development of the guidelines, and due to some of an outcome of the politicking was that the borderline pattern was retained. There's also a category for personality difficulty, which is not, I think it's very important for us as psychiatrists in terms of diagnosis. If we're saying personality difficulty, it's not fitting within the category of personality disorder. It's very important to keep that distinction. So you can see how radical this is, that in a way, if you look at ICD-10, it's got all of the, the groupings that we are familiar with. Whereas once we get to ICD-11, it has no specific personality disorder other than allowing us, if we want, to specify a borderline pattern. So step one, is a personality disorder present? Yes or no? And you know, the point about it, if you look at the guidelines, it's not very operationalized. So you can see in terms of what's in the guidelines, it's quite sort of wordy what's put over there. What you should be mainly thinking of is, if you see what is actually saying, what they're asking is to determine whether a personality disorder is present, yes or no, to think on self and interpersonal functioning, to think of thought, affect, and behavior, and is the difficulty presenting persistent, pervasive, and problematic. So if you keep those, that's a way to just structure what's quite a lot of text. Again, when and this already is an attempt to simplify, but when ICD-11 proposes how we assess severity, it's not easy to sort of keep all of this in mind, and some of it is a bit iterative. So, for example, how do you diagnose a moderate personality disorder in terms of disturbance in functioning of self? It then says the definition is this more pervasive and it's moderate. You can see it's a bit circular in terms of the ability to operationalize this. So now this is, so that's, dietary guidelines. I'm now going to say this is how we think about it within my service, that in a way, the way that we're trying to simplify it for ourselves is we divide it into self and other, and we think of the main aspects in terms of making the definition, the diagnosis of personality disorder, thought, affect, behavior, and the one that, in terms of behavior, which is particularly specified, is about self-harm. And then we think in terms of self, is it persistent, pervasive, and problematic? And we repeat the same set of questions in terms of thinking about the other. And then this is step 3. So remember, it's steps are 3 steps: PD present, yes or no. What's the level of severity? And then step 3, what's the flavor? And these are the trait domains which determine the flavor. So negative affectivity, detachment, social aspects, disinhibition, and incastia. And I've highlighted in yellow, this is ICD-11. When they say negative affectivity, this is what they bring in the following emotional aspects: anxiety, anger, worry, fear, vulnerability. Just a sort of a listing, really. And remember that we said that the one specific personality disorder which is retained, which we as clinicians are still allowed to state, is borderline personality disorder. And I'm just reminding, and it's based on DSM-5, I'm just reminding you of the specific 9 criteria to make the diagnosis of borderline personality disorder. So in terms of the crosswalk between ICD-10 and ICD-11, we can see there's some, one is able to sort of map them onto one another. For example, around borderline personality disorder, you can see that it maps onto the ICD-10 borderline personality disorder, maps onto negative affectivity and disinhibition. And again, what's very important is to think that how does ICD-11 link to DSM-5? And again, there's quite good linking in terms of also emphasizing, by the way, this is the alternative model. So DSM-5 is DSM-4 in terms of the main section of DSM-5, but there is an alternative model for personality disorders, which is what maps, that section maps onto ICD-11 in terms of level of severity, and you can see the criteria, the domains are the same, really. This is just looking at how the self and other link to how ICD-11 and DSM-5, you can see again the close linking in between the ways that ICD-11 and DSM-5 approach personality disorder. So hopefully I've conveyed it's not too complicated. I think we can overcomplexify it. I think the actual technical application might be more difficult, but in terms of the knowledge or the theory, it's fairly simple. PD present, yes or no, what's the level of severity, and what are the predominant traits? The experience within our service, so it's just, so again, this, I'm just stepping out, I'm just talking a bit about our, not all of ICD-11, but just how we've used it. In our service, it's not been difficult to learn, and we're a multidisciplinary team. Not all of the members of the team are medically trained. And we have, in terms of our approach, because of the speed at which we need to work, we've developed, before ICD-11, thinking about caseness, impact, and frame. And you can see that we were thinking clinically, and ICD-11 bring in this way, which is the same. It's PD present, yes or no, caseness, severity as an impact. What we found when we've been using ICD-11 is that it's got good reliability and validity. And again, because we are a personality disorder service, what we found is that by thinking within this way, it starts helping us to think in a more psychological way, because it is talking about object relations theory. It's talking about self and other. So level of severity is something we certainly would look at in terms of, is this patient for a specialist PD service? Where we have, as a service, have more questions is the use of trays, and we're very interested in, whether you, in terms of your psychiatric practice, are actually going to use the domains that ICD-11 have proposed. So in terms of how our service works, we are far more interested in the levels of personality organization. So again, that's a measure of severity. But we are, in terms of the flavor of the personality disorder, we still are particularly interested in a borderline or, for example, narcissistic or an antisocial presentation. This is based on Kernberg's work. In a way, it's been acknowledged that Kernberg's levels of personality organization was what influenced the alternative model in terms of level of severity. Again, this was a paper which just said ICD-11 is starting to talk to a psychodynamic way of understanding self and other relating. And again, this is just linking in the different important aspects that psychodynamic thinking thinks are important structures of personality, and linking it in to some aspects about personality function. But ICD-11 describes itself as, so this is a personal comment now. ICD-11 describes itself as pan-theoretical. I think it could also be described as atheoretical. It doesn't have a theory. And so, within this trust, we, I suppose, we're wanting to practice thinking psychiatry. And so just to, hopefully you can reserve the dates on we've got a trust-wide teaching plan for the 10th of April, where exactly what Richard's been saying about trying to develop a way to formulate, which is provides a psychological understanding of what's happening before us. So that's something that we will be attempting to do. In other words, building from ICD-11, but trying to build in more of a thinking frame for it. I just want to end off on, we often get thoughts about, well, what's, where does complex PTSD fit in within borderline personality disorder? So just to be clear to ourselves, this is PTSD. PTSD is the criteria of re-experiencing avoidance and threat. the criteria for complex PTSD is all of the criteria for PTSD plus issues around relationships, affect, and self-concept. Now you can see, if you think back about the thinking about ICD-11 personality disorder, and if you think about borderline patients, you can see why there's this potential difficulty in diagnosis that one can sort of think, is it this or is it that? But if one sort of digs deeper into actually looking at the clearer description, there is a difference in terms of how patients are presenting. So, for example, if one looks at relationships in a borderline patient, there's clearer history of impulsivity and self-harm. If one looks at affect, the complex PTSD patient is more persistently negative, whereas in a borderline patient, there's a greater instability. And in terms of self-concept, the complex PTSD patient is avoidant, whereas it's far more changeable within a borderline patient. So this is work that's come out of our patch. This has been, we've done a systematic review comparing complex PTSD and borderline personality disorder. And the conclusion is that most of the studies thought that they were distinct conditions. So I think that's an important, that's from the systematic review. These are just, this, the Bach paper is excellent. So I'd recommend it. All of these are freely available, they're all online. But the first one, I think if one reads that, one will get, it's exactly what I've just said to you already.
Great, thank you so much, Tennyson. So that's the second of our three speakers. As you can see, we're not quite running to time. We started a little late. There was a technical issue. Apologies. What it means is that we won't have so much of a plenary. There could be maybe space for a couple of questions for our three speakers, but I'm going to offer them forward for conversations in the coffee break, and then we will be having the discussion later. So there's scope for questions and time for that. We're just going to get the slides, which, yeah.
Have you done?
I clicked stop sharing. Yeah, there we go.
That's
Okay, thank you.
Fantastic. So thank you very much. And I think some of the delay is my fault because I arrived late and I was messing people around with slides. So I promise to be very concise because I don't have a great deal to say. But actually, this is such a fascinating afternoon and I'm really pleased to be here. The reason that I have come along today is that Richard and I and other colleagues have recently secured some research funding, and I was asked to come and talk about that. We're not actually allowed at the moment to say who's funding it or what it's called, but it is going to be a large-ish program of personality disorder research, which we're really excited by. And one of the key sort of fundamental bits of what we're proposing to do is to make sure that it's really strongly founded on lived experience. And in keeping with that, I'm going to share some of my lived experience. And one of the lived experiences that I will share with you is, as I was walking over here today, I realized that it was 40 years ago that I started at medical school here. Well, I came here to do my clinical work. And I was also remembering that those were probably about 3 of the most miserable years of my life, because it was really, I really didn't like clinical medicine, and I wasn't a very good medical student. But that got me to sort of thinking, you know, and remembering some very salient kind of experiences early in my career. And when I went to did my psychiatry training at Maudsley, as it was then, I was fortunate enough to spend some time in what was the general practice research unit, which is where I really found, you know, my home in terms of my research interests. And I'm reminded, you know, even way back then, people were looking at and very sort of confused by patients who had what they used to call, you know, fat folders, patients who were clearly had mental health problems and were frequent attenders. And it's no surprise, you know, that those patients had many and multiple diagnoses of the sort that Richard has talked about. And, you know, we're very much in the kind of core of what we understand as personality disorder. I also remember my job when I was first a psychiatry trainee was that I would, you know, go to the new outpatient clinic. I would take a really thorough and detailed history and do all the things that a really sort of diligent trainee does and present it to the consultant. who was a very eminent man and a great mentor. And then my job was kind of going after the patient who would leave in a flood of tears, having been told that they have a personality disorder for which there are no treatments. So we've moved on just a phenomenal way, of course. And, you know, this field is a lot known now about personality disorder. We can have really informed discussions about neuroscience, about diagnosis and diagnostic classification, but lots been researched, but we still don't know a great deal about how to help people who have personality disorder. It is, you know, as Rich said, you know, it's this kind of, you know, back and forth between what we learn through sometimes our rather clumsy clinical practice and what we learn through the kind of evidence and through, you know, modeling what really able colleagues do. But what it very much used to be, and you know, what many people with borderline personality disorder will tell you is that it is a diagnosis for exclusion and not a diagnosis of exclusion. That it's that the main experience, the experience that's described, is probably more stigmatizing than in any other mental health problem, and that people are seen by professionals, and you know, this is well documented, and probably well-meaning professionals, as difficult, as kind of help rejecting, and that sort of dynamic of trying to get help is often very unsuccessful on both sides. And, you know, we've all been there. It's I would say in my career, it's absolutely at the kind of heart of what I do. I have moved further from London, and I've moved northwards via the Midlands, and I'm now in Sheffield. And I've moved more into the kind of heartlands of the CMHTs. And it is, I would say, you know, 75, 80% of my clinical practice, whether I like it or not. These are the people that we are helping and the people that sort of struggle. So we really want to take forward this research. And what we're proposing to do is to try and work in a way that tries to navigate some of the impasses that Richard described, and to do so through a way that's sharing kind of learning across and between disciplines and with lived experience experts, that we want to know more about the actual experience, which is right. You know, many people bring great strengths and resilience and, you know, have very successful lives despite having an experience of childhood trauma. So we want to understand what it's like living with the symptoms of borderline personality disorder and how people successfully navigate the landscape in which it's not just that they live with a memory of trauma, that they live in a landscape of repeated triggering of trauma. And how do people do that? And we want to understand the social and circumstantial factors that both cause distress and also allow people to get on successfully. There are lots of ethical dilemmas that we want to wrestle with. We are very aware of the kind of neuroscience that tells us a great deal about what is happening in people's bodies and brains, but we want to go one step beyond that and try to identify ways in which we might be able to help. And the pathway is, I think, between understand, you know, the core, we know what the core phenomena are of borderline personality. So we've heard them already. It's this sort of disturbed interpersonal relationships, often associated with unstable sense of identity and a fear of rejection, emotional dysregulation, difficulty, and impulsivity. And we know, and I know as a clinician, the thing that we worry most about is that pathway that leads to high levels of distress and impulse, and either kind of breakdown in relationships through kind of volatility or self-harm or mental health crises, as we might refer to it. And what we don't really know, I mean, Tennyson has spoken about the sort of ICD-11 notion and chronic PTSD or complex PTSD. What we don't know, one thing we don't know is whether there are genuinely sort of stable subtypes, phenotypes, actual kind of clusters of symptoms that are stable over time and, you know, have discernible trajectories. We don't know if that's true or not. We also don't know dynamically how the different symptoms, and Richard put up a really good slide that showed all of these different clusters with their individual symptoms, we don't know how they kind of play out in real time. What we often know from our patients is that they have had a crisis, and they'll tell us, either because they're still in it or because it's past, and we'll talk to them about what happened last week or 2 weeks ago. We really need to be able to map things in real time and then to intervene in real time. So that's one of the things we want to do around what we're calling dynamic phenotyping. We will also do qualitative phenotyping, where we're really trying to kind of at depth understand people's lived experiences and what they're going through and how these processes play out in their lives. We want to understand how people experience seeking help. And so I would say we have had to get the funding. We've had to use the diagnostic terminology that was required of us. But other people have used different words. I would say that I am both trans-diagnostic in approach, but also diagnostically agnostic. Richard's highlighted the fact that these problems occur frequently outside of mental health settings. So that's where we're going. And when you do that, and we expect when we do that, that we will find that there are some people that say, oh, I wish I could get a diagnosis, but nobody will see me, or the waiting lists are too long. And other people who absolutely reject and don't want the diagnosis and find the term sort of hurtful and harmful. But we know what the problems are. So we're going to be working at the sort of problem and the sort of symptom level. Hopefully we'll come up with some learnings. We want to use some new technologies, including data science and AI and all sorts of clever things that I don't understand, but my colleagues are smart enough to be able to help with, so that we can see if we can generate a meaningful system map that has some points at which intervention might be potentially helpful. We want to see if we can then go beyond our research to see if we can find and validate these phenotypes and patterns in electronic health records, and especially in primary care data. And we want to work with care providers, not just healthcare providers, to understand what it is that they need in order to be able to provide exactly the sort of care that Richard and his team have tried to deliver. And I'm reminded, of course, that the world in which we were told 10 or 15 years ago that there would be personality disorder services everywhere is never going to happen. You know, we've got to skill up people who might not even see themselves as primarily mental health professionals, because these problems are just so prevalent. We will do some intervention development and early phase testing, and hopefully over the 4 or 5 years that we'll be working, come up with something that will be a practical and useful benefit to professionals and to people with lived experience. That may have raised more questions than it's answered, but I will stop there.
Thank you so much, Scott. Something I should have said at the beginning, which is a huge thank you to Cambui, who sends his apologies, and sadly he can't be here, but between Professor Bui and Tennyson Lee, they put together this afternoon, and actually Tennyson rightly identified me as one of the few clinicians in Elft who would happily chair a debate about personality disorders with 2 days' notice. So that's why I'm here. But apologies from Prof. Bui. If our speakers could come up, we have some time for questions, then there will be the coffee break, and then a sort of broader discussion in a debate format. So come on up. Oh, sorry, I'm blocking the camera there. So you've heard from 3 speakers, different backgrounds and perspectives, all within that same sort of umbrella and theme. I wonder if people want to pick up any part of it, maybe clarify something, gather a bit more detail. It's really over to you if there's something you want to come back to in the next 10, 15 minutes. And then, yeah, bearing in mind, we've got a coffee break and then more of a sort of debate about the utility of diagnostic labels. But coming back to our speakers on any of their slides and thoughts. I'm explicitly favouring the room rather than online, because it's just easier for me to run around than do the tech. Yeah. Let me give you the microphone and get the other one working.
Hello, I'm John Sterling, a consultant psychiatrist in Newham. I'm quite surprised they've retained borderline as a term in the new ICD-11, because I feel it's probably the one that patients find most confusing, and when I'm asked, it's not a Madonna song, but or you're kind of borderline not quite there or something, I've had all sorts of responses to that. So I just wondered what people thought about that. I actually kind of feel emotionally unstable is a bit more descriptive of what they're going through, although also can cause offense sometimes as well, but borderline, I feel generally people do not understand what it means. And I'm kind of surprised they haven't reframed it, as I think that's probably one of the most stigmatizing words.
And it begs the question, how all have we explain it to people when they say, what does that actually mean? And you go, oh, it's the sort of board. Yeah, over to the panel. Anyone who'd like to comment on that word and the use of it, the retention of it?
Just give a straight practical one. And, you know, Tyra's written a paper called something like Science, Politics, and What Happened or something. And it's about exactly the background to ICD-11 PD. What happened is that Tyra and his group were absolutely clear that there would be no specific personality disorder. And the PD specialists pushed back. And in order to get overall agreement, there was an acceptance of that. One of the arguments of the PD specialists was that there's an evidence base for borderline personality disorder. So all I'm saying is, I think it's an absolutely great question. I think it, you know, there've been the task group leaders of the last 2 DSM iterations have said they're surprised at how psychiatrists reify diagnostic systems if they knew the level of politicking happening in terms of what happens about the groupings. We might reify diagnoses less. So I think it's a really useful point.
Is it fair to say it's factional infighting between psychiatrists that doesn't really help patients? Is that a bit unfair? Anyway, sorry, that's me. That's not quite my role. But I'm just unhelpfully summarising that, Tennyson. Would the other, do you want to comment on the borderline or go more questions? More questions? Yeah, on there.
Hi, thank you very much for your presentations. I'm Gökçe Serdoğan and I'm working in the Community Mental Health Center. So we have a lot of patients who are diagnosed with EUPD and who has very different characteristics from each other. So I'm going to ask you something from my free association and my observations and give you some of my observations. Nowadays, I see some different diagnostic states such as autism spectrum disorders, substance use disorders, personality disorders, and as well as complex trauma, post-traumatic stress disorder diagnosis that are all confusing and mixed up all together. And there are like very particular points, for example, with the autism spectrum disorder as like mentalization, lack of mentalization capacity. Like, so many people who has EUPD nowadays are coming and saying, oh, may I have autism? Is it a wrong diagnosis? Or in another case, this is, I'm just going to give another example. Like, for example, this is what I observed so far. For example, if somebody is using substance or like who has an alcohol dependency, they can show up as a personality disorder, and their defense mechanisms go to the more, how do you say, they cannot use the higher defenses. So I would like to ask your opinions about how this will be separated in the future, or how will that be defined?
Yeah, I'm not sure. I think I could have explained some of, you know, my experience of working in a personality disorder service for 20 years now, in which we don't use the diagnosis, but we absolutely get lots of people turning up with lots of diagnoses, and it's very confusing. And so one of the jobs I often am asked to do is to help people think about what's going on and provide a different explanation that brings those things together. And I think, you know, ICD-11 has made a small step in terms of function and you know, different components that's more of a typology rather than a diagnostic process. So I think it's one small step, but I think we have to think about the actuality of reality in our explanations. And I think lumping together different things in, you know, so that impulsivity is a kind of is the link between a thought and a behavior, and we should think of it like that. And the behaviors of self-harming and alcohol consumption and hiding away inside because you're scared of triggering, you know, or fighting or whatever, should be seen as behaviors. And so we should really start to think about ontology in this, and then and then help people understand what's happening in the mind, and so that they can tell us that, and then understand that that might link to behaviors that they've got some control of, and that also might link to a load of stuff in their brain which is very hard to control, but they might want to understand it. And just on the diagnosis, I've had 2 patients in the last month who've asked to be undiagnosed. I've had to write to their GP and say, you know, one of them tried to persuade me to put a diagnosis in the letter 2 years ago successfully. They wanted the diagnosis, and now after being in Icebreak, they don't meet the criteria anymore. And I'm able to undiagnose them, but it's a shame that I had to do that.
And for them as well.
Yeah, but it's the cultural phenomena that we've created in our mental health services that has meant that we have to do that.
Yeah, I would agree. You know, we are very sort of stuck on wanting to classify things. I mean, even when we try not to, we sort of still find ourselves coming back to it because there is some explanatory power in having these sort of diagnoses. But I think the reason why ICD-11 moved away from the categorical sub-diagnoses of different personality disorders was because the logical kind of extension of our poor and limited classification system was just the accumulation of multimorbidity. You just got lots of diagnoses, which you don't get in other bits of medicine. So we used to sort of square the circle by saying, well, there's comorbidity, of course. But then, you know, how many diagnoses can one person have before you think that the system just isn't right? And Richard's right. So it's thinking transdiagnostically, I guess, and at symptom level and problem level. So far, the models that the transdiagnostic models, I think that we have, things like our doc, just haven't quite got there yet. But I think we have to kind of keep coming back to what we think is going on underneath these problems. And it may be, you know, there are multiple problems, but actually a lot of the problems are, for instance, just different bits of kind of poor impulse control, for instance. The thing I think that characterizes borderline personality disorder particularly is that it is so obviously interwoven and comorbid with other conditions, which we can either see as, well, let's just collect more labels, or actually is this something about the underlying phenomena that actually, why is it so common with, you know, so often linked with PTSD and bipolar disorder and substance misuse? I think we just have to dive a bit deeper, really, to understand what's at the core of this.
Thank you, panel. We've probably got time for 1 or 2 more questions. At the back, is that, yeah, hi, Susan. Make me work.
Any reflections on the psychotic experiences of people with complex personality?
I mean, yeah. So I'm very lucky to be supervised by the psychiatric lead for the early intervention service. So we work in teams, we're sister teams within a third sector organization, which is unusual. And so we're always kind of adjudicating whether patients go in one service or the other. And probably 30% of the patients in the early intervention for personality disorder service have quite significant sort of experiences which could be sort of classified as psychotic, but you know, they're not. We don't classify them as psychosis. So yeah, but you know, hallucinations of various types are incredibly common, and you know, borderline delusional states are incredibly common.
Having brought the microphone all the way down, I wonder if we can, did you have a thought about it behind the question? Was it more about diagnosis or about the underlying
I think that's another whole CPD session, different kind of belief systems and experiences, fluctuations, stress, and Tennyson
it sort of absolutely challenges us clinically. It really does. It makes people very uncomfortable. And I mean, coming back to the notion of sort of borderline, you know, it's still so many people are still stuck in this idea that problems are either sort of neurosis or psychosis. And actually, if you start to get things that don't quite look like the archetype, people get uncomfortable. Again, another sort of ancient sort of memory I have as a trainee, as I once worked for, and in the Maudsley, where they used to have, back in the day, they had an inpatient unit for psychotherapy, and people who would have their sort of dreams interpreted the sort of next day, and a lot had hallucinations and psychotic experiences. And I went to work on that unit as it was changing hands and was taken over. The consultant was one of the most eminent global schizophrenia researchers, now no longer with us, and I won't say who it was, but he was a leading figure in schizophrenia research. And literally, we spent the next 6 months where all the patients got re-diagnosed as having schizophrenia, because that's what happens. You know, we build up rules based on what we think the world is meant to look like, and then we apply the rules, and then the world looks like, you know. So, clinically, I think we're all very familiar with the fact that the patients that we see who have personality disorder, who frequently describe, you know, very disturbing and distressing hallucinations, they don't respond to treatment in anything like the same way as some of our other patients, and that really challenges us.
Just one,
And I'm not sure about.
behavior, distress,
Thanks, Hugh. I hope everyone heard it. The individual's desire to seek help might be a helpful way of thinking about their difficulties. Did you want to come back, Richard, on Scott's point?
I think in terms of the, you know, the psychotic experiences, I tend not, that's not my experience. I think people tend to find them incredibly distressing, and so I think you know, I'm aware of that as an explanation, but it's not something that I feel is very correct very often. In terms of the treatability, I think we're not good at treating, and we're always surprised, I think, whether antipsychotics work for some things or not. And you know, I do use small doses of antipsychotics judiciously, and sometimes I'll be using it intermittent, so for patients to choose when they use it. You know, very often it seems to have no effect other than the sedation, but occasionally you're surprised and they have really clear effects, even for this group that are classified by us as on the borderline side rather than the psychosis side. But they're both broad syndromes. They're not things. We keep using them as a noun, but they're not things. They're things they are constructs that we've invented.
That feels, unless there's a final comment, as though you're almost stepping into the debate. So I think we can probably, in a nice way, that's a nice segue, you can step into it. So I think everyone probably needs a breather for coffee. Thank you so much for your attention. We'll move into the next section in about 15 minutes. If you could all come back for quarter two, if that's all right. Thank you very much. Welcome back, everyone. Thank you so much for coming back. We have the second part of the afternoon now, which is the debate, followed by some closing remarks from Scott. Just a few things to say before we start. The first is the practical one, which is hopefully quite a few have already used the Mentimeter. If you use menti.com and then the numbers at the top, it's just that one question, which gets us started with thinking about the debate. But I just wanted to say a word or two about the debate. As Tennyson and I were speaking yesterday, the day before, about this, we're using the debate format, but really this is a space for us all as doctors, perhaps some of us as patients, relatives, to think about diagnostic labels, particularly, you know, around personality disorder. So that's really what we're aiming for, as much as a kind of for, against, and win. But we are going to use the debate format and encourage our speakers to push for their sides. Just a couple of things before we start, which is that in making a comment afterwards, you may want to draw on your experience, but these talks are recorded. They are then circulated. So please bear in mind not to say anything that could in any possible way be identified as a patient or in that way. The only two other things I was going to say is that you don't have to be a man dressed in black to be up here, but that is what it's ended up being like, which we realise here in the way that these things do. We shouldn't really be having all male panels in this way. Another reason why I should have said no, but just wanted to at least name that in a way that perhaps part of treating these sorts of difficulties is to name difficult things. And the other last thing is a particular plea to sort of hear from people who are perhaps earlier on in their career in psychiatry, who might hold, you know, different experiences, different ideas from those who've been around forever. And maybe I think that's part of what we've got in this room is different perspectives, different services, and different sort of careers that we can then draw on to talk to this topic. That is enough from me. Going to hand over to our first speaker. And I'll just sort of wave when it's time.
Yeah, get rid of me. Yes, thank you very much. Yeah, so I'm speaking for the motion. This is because I would really love us to be doing better mental health care. And yes, I have over the last 10 years become quite skeptical and even advocating against diagnosis in general. And there are many people who've articulated this, you know, these arguments. The first kind of main thing to get out of the way, I think, is that patients like diagnosis. And I think some patients like a diagnosis and some patients don't like a diagnosis. I think we haven't got any really good systematic evidence about how much people with personality disorder, as it's defined, like a diagnosis, particularly those that have not been diagnosed. And we also don't have very good evidence as to whether it's helpful to go down the diagnostic line or the formulation line. So I think there's a lot of views on both sides, and we should discount that as a kind of a rationale for making a decision on this. If we think about it at a utilitarian level, I think that's probably more important and might help us get to things. How useful is this? So some people like a diagnosis and want a diagnosis because they need a diagnosis in order to get the treatment or support or benefits they have. I think that is the case at the moment, and that's why a lot of us use diagnoses in certain settings. But I don't think that's a good argument, because we can change that, and we could change what the benefit system, the housing associations, etc., ask for if we come up with a better solution. Secondly, I think there is a kind of issue around communities and kind of divisiveness, and that there's a diagnosis has escaped not just from psychiatry and psychology into primary care, but into the community wide. And I think there is a problem which we also haven't really investigated very well as to whether it's helpful or not for communities to be talking about diagnosis and young people of 13 to be saying, it's my ADHD, or it's my EUPD that's the problem. So there is an issue about agency and whether the diagnosis itself has an impact on agency. In terms of, you know, whether it's a good enough model, because really it's a model, isn't it? It's a syndrome, let's be clear. It's not a thing, it's a cluster of symptoms, and the diagnosis is a syndrome. And because of that, it's got lots of weaknesses in terms of being a model. It represents what's going on in the consciousness, but it's aiming to represent something and keep using the noun to represent something going on in the brain. And I think all the evidence is that it's not very good at that. So it's a very poor model. And it's inconsistent, it's changing, there's overlapping. And I think some of the worst things is when you have multiple diagnoses and you're insistent on keeping a diagnostic way of working when you have someone who really needs to help to understand their one brain body and not see themselves as having multiple things. Perhaps finally, I'd like to argue from a kind of science point of view. I think the diagnostic system and diagnosis for borderline, EUPD, has been really harmful to us understanding what makes things better. So as a researcher, when you start with a category that is so flawed and you put that at the center of your research, it's not surprising that we haven't made progress. If we start to think about the real things that are going on, what's actually real, which are the experiences and the brain circuit imbalances that are going on underneath, then we might make some progress to working out how to support people. When we lump all of these people together in one category, when they have violently different things going on in their brain and their consciousness, it's not surprising that we are not making progress in helping people. Thank you.
Thank you very much. Very clearly and succinctly put. I'm just going to encourage people not to vote any further because we'll come back to that and do the same vote in about 45 minutes. So don't vote anymore. Over to our second speaker, Tennyson.
So I'm going to speak to 4 points, and I've seen how the vote is, and I hope that it'll swing even more to. So I'm going to appeal to, exactly as Richard has done, to the science. I'm going to discuss the problem with labels. I'm going to say, where are we now? And I think I'll finally be addressing you as mental health professionals and as mainly doctors in the audience. And I think on the basis of all of that, I hope to sort of push it even more to the disagreement with the House's proposition. So in terms of the first point, the science, I think that if one has an understanding of the present evidence about the brain and the acceptance that there are basic emotional systems whose needs need to be met. So, you know, some of the systems that have been identified have been, for example, lust, the need to have a partner, panic or grief, the need to attach to others. Now, if one thinks that these are systems which are just built into the brain, by definition, those needs can only be met by an object. You can't meet them yourself. In other words, it's built into the biology, the need to seek, to go out. Now, and I think it comes back to the themes that have been identified so far this afternoon, and that is, what is the expectation of the individual who comes to see us? If they have a problem, what is the nature of the problem? And looking at the affective neuroscience, one can think the nature of the problem is an unmet emotional need, which by definition needs to be met by the individual going out to meet those needs. So it's a very important biological point. It's not a philosophical point, but clearly there are politics around this point. And, you know, again, I'll say it's the science. If we think of the second law of thermodynamics, we as any living system need to work to resist entropy. So in other words, there's a need for activity in even the smallest cell. So if we build it up into us as individuals, for all of us, there's a need for activity there's a need to go out and seek, sort of satisfy one's needs. So that's the first point. The second is the problem with labels. Now, we have our patients who might say, I am neurodiverse, or I have complex emotional needs. I think it's to ask, what does it mean? In terms of the complex emotional needs, I suppose it begs the question, all of us as human beings are pretty complex. So how does that describe the individual who's coming for to seek help? And again, speaking clinically, you know, time after time, the patient seeking treatment might say, it is my neurodiversity. Now, the patient might say the same, like, it is my personality disorder, but there is something about the concept of personality which brings in affect, thought, and behavior. So there's something built into the term which may be helpful for us in terms of thinking, how do we as clinicians respond to the individual in front of us. I'm going into the third point now. Notice, where are we now? So where we are now is we're at a better place in terms of how we classify. And, you know, Richard's point is so well taken. We're not at a good place, but we're at a better place at least. We are now at a place where we are acknowledging that the issue is dimensional. There's an emphasis on assessing the level of severity. And the other important point is we are at a place where there's an acceptance that the problem is psychological. It's about self and relationships. So again, we're at a better place than we have been at the past. So why ditch it now when we're moving towards in the right direction? The other is from the evidence in terms of where we are now, that when, and this is from a systematic review, when patients are asked, what is the difficulty around the diagnosis? It's not around the diagnosis per se, it's about the communication of the diagnosis. How is the information conveyed? And again, in terms of my own practice, patients,
30 seconds.
Patients, they, you know, have some relief about it. So about just hearing the diagnosis, just to round off, I'm, I suppose, raising the issue in terms of the science, in terms of the pragmatic nature of how we can respond as professionals, and that our role really is to make an accurate diagnosis as we can, manage and treat. And there is an evidence base for the treatment of, in this case, borderline personality disorder. I think the main emphasis is how we improve our practice, including around communicating the information. So thanks very much.
So the format we have is that our first speaker can come back for 2 minutes on any of those points, and then 2 minutes from Tennyson, and then it'll be over to all of you.
Great, thanks very much, Tennyson. Just some kind of points of rebuttal. First of all, on needs, I think needs are really important. I completely agree. I'm not sure that your explanation provides a rationale for not having diagnosis. I think people have emotional needs and needs to understand, as well as social needs, and we need to look at those together. I think the complex emotional needs argument, I don't think that's a really very helpful expression. I agree with you, because it doesn't actually explain and it doesn't help create an understanding very well. Whereas I think, you know, I agree that what's happening in DSM-11, in ICD-11 is helpful in that it's starting to look at dimensions, affect, thought, and behavior. But I would add the range of other things, and particularly perceptions, which is where, you know, the PTSD overlap comes in, as well as psychosis. And I think what we can move to is a situation where we've got an explanation that is worked out with an individual that helps them understand. And if you're dealing with dimensionals, then it's not categorical, so it's not a diagnosis. So fundamentally, if we're shifting to dimensional, then it stops being a diagnosis. It becomes a set of things that you might think you might be concerned about yourself and wonder about, and start to be interested in how you can change, or how we can help someone change. And that explanation in that way tends to be much more helpful. And when I have people who want a diagnosis and I provide that kind of explanation, they very rarely at the end of it then want a diagnosis. I offer it. Would you like now a diagnosis? Nearly always they say no.
Thank you. Bang on time. Over to you, Tennyson, if you need it for 2 minutes to come back.
No, I'm having problems in finding differences with Richard, but that is the nature. If we think about how we can draw a difference, I think it is accepting that it's a moving target, that there are at least 7 emotional systems at play. And the way to think about it is that a personality disorder coalesces around some overlap when one sort of intersects the different emotional systems. So I'm proposing that it's not ideal, but it's better than any alternative at present, and therefore we should stick to the, you know, using, and absolutely, it's a disorder. Colleagues, it's not a diagnosis, it's a disorder.
Thank you very much. So a reminder that the vote at the beginning went pretty much 3-1 in favour of keeping the diagnosis. So it's now over to all of you for about half an hour. It would help us if, just to keep broadly to the debate format, if you want to start by saying for or against diagnosis, and then you can make a point or a reflection. Because we are psychiatrists who want to encourage a kind of depressive position or healthy ambivalence, you can say abstain if you want and that you're on the fence. But I'd encourage you to say at the beginning if you're sort of more for or more against. And yeah, using some of the things that we've covered this morning or from your own experience, if anyone wants to say anything, over to you. Otherwise, it'll be an awkward half hour of me doing some stand-up, which I don't do.
Yeah, so I'm for the diagnosis, but now heading towards against the diagnosis in the last few years of my work. I find that people who've come into the clinic have a diagnosis of EUPD, but actually don't have any of the features of EUPD. So I just wonder how you manage that, Tennyson, really, that are they no longer caseness? Are they no longer personality disordered? And are you then saying that you move within that diagnosis, in and out of the diagnosis? Or are you saying that they have it, but they're at the moment in some sort of remitted state?
Thank you. Just because of the format, I'm not going to put it straight to Tennyson, but I think it's really important. It reminds me of a paper that Emma Janes put me onto, former psychotherapist in Hackney, that 10 years post-diagnosis, about 60% of people didn't fulfill the criteria. I need to track that down. I'll send it to you. But it's a good point. People, if you're not holding on to those factors, what are we actually describing? Sorry, I'm supposed to be neutral, aren't I? I'm just bouncing things around. Yeah. Anyone? Yeah.
I spoke earlier. Just a few thoughts, and I suppose I did vote for, I'll be honest, but I have quite mixed feelings either way. I'm not sure it's quite as simple as for or against. I don't quite agree with this on completely. There's a few thoughts. I think this is relative to all of psychiatry at the moment, but GT is quite a lot. Is that I don't think we formulate patients as much as we used to. Maybe due to time constraints or lack of psychology input, all of these things. And I think often a lot of the time we should be kind of treating the symptoms in the person and the individual issues that they have, rather than getting something too fixated on a diagnosis or disorder. So that's one thought. The second is just some personal experience about, I work in a CMHT in Newham, part of my job also in patient. And I just wanted to comment on the kind of mass exodus of psychologists in the NHS right now. They watch on being shipped private. I think partly in COVID, due to the fact that now everything can be done online. Why would you work for the NHS? It's at home and make a lot more money. So in our CMHT, we've had no psychology for 10 months now. We had psychologists for a brief period before that. Before that, we had no psychologists for 18 months. So that's in the last 3 or 4 years, we've had almost no psychology. And we're a CMHT for secondary care. Pretty poor. We're still looking. But, you know, we don't really formulate anyone. I think, really. I mean, I suppose we do a little bit, but we don't have maybe the formulation discussions that we should. And we don't have psychological interventions to offer people in a CMHT, which I find very frustrating. And my third point is just about sort of structure, not so much in the CMHT that I work in, but in other trusts and other boroughs I've worked in. Things are now divided into psychosis service, depression, anxiety service, personality disorder service. And there's always been people that kind of, you know, don't quite fit one, don't quite fit the other, get bounced between the others. And when I worked in those kind of styles, I just felt like people being bounced all over the place, and we weren't thinking that actually people can be psychotic and have a personal disorder. People can have OCD and personality disorder. You know, the idea that you have one or the other doesn't fit. So why did we structure services that way in what areas? So just a few thoughts.
Thank you very much. And then sort of a hand up or eye contact.
Hi. Yeah, so echoing the thoughts around formulation, it feels like the lack of formulation as opposed to diagnosis harms our ability to formulate what's the best treatment plan for people with PD, but also people without PD, I think, because if you formulate, okay, well, this person is avoidant, this person, you know, has difficulty with mentalizing, that will maybe actually guide you, you know, towards what they actually need. Whereas a diagnosis of BUPD really doesn't, other than refer psychology if you have psychology services, or if you have MVT, who seemingly always rejects referrals in my area. But also, I'm seeing lots of people so I worked in the EIS before, I've just worked in the inpatient service. We have lots of people with psychosis who also have a lot of trauma history, have a lot of interpersonal difficulties. And can we get them seen by a psychologist for that stuff? Absolutely not. We can't, because their diagnosis, their primary diagnosis is not personality disorder, it's schizophrenia. So the fact that we're not formulating screws them over just as much as it does people who have a PD.
Yeah.
Hi. I think I am for now for the diagnosis, not because I think it's perfect, but I think we need to be a bit pragmatic, and just because it's not perfect, as Tennyson said, doesn't mean we should throw it out. And, you know, what do we have something better at the moment? I was also thinking that it seems we have a tendency to question diagnoses that don't respond to our drugs. Is this the psychiatrist's feeling a bit impotent? This is actually a thought that a colleague put into my mind in a recent discussion. But, you know, we have psychiatrists questioning personality disorders, complex PTSD, dissociative disorders. And, you know, nowadays we're meant to be psychiatrists that are more biopsychosocial. So are we questioning this diagnosis, even though there's evidence for effective psychotherapy? That's what I'm wondering.
Thank you. Excellent points. Was there another? Yeah, pass it across. Thank you.
Just a bunch of thoughts. I'm somewhere in between. I feel like a diagnosis helps if it, you know, some people are very relieved, as any clinician will say, some people are very relieved at having that diagnosis given to them. Some people, after having had the diagnosis for a long time, get frustrated by the labeling that it causes, and especially in acute services. also, again, talks like this always leave me a bit more confused than I started out, is because I find it very difficult to differentiate between the different schools of thought and the formulations that sort of feed into the diagnoses and the overlap that inevitably happens. If I look at clinically, it's just, my impression of the next person that I'm seeing depends a lot on the last talk that I've attended. And this is just, I don't know if other people share this with me, but also if I look at developmental history of a lot of these people with varying diagnoses. So somebody with a lot of emotional instability, with predominant negative affectivity, with a lot of trauma history would possibly go more in the direction of complex PTSD. Somebody with a very similar history in their background with more rage reactions would possibly be labeled as having EUPD or borderline personality disorder clinically. And both of these people might benefit from mentalization-based treatments. So it just, again, it's more about navigating services. It's more about psychiatrists not being able to provide the kinds of treatments that will help these people because we are limited in our scope of practice, and services exclude these people. So again, all I'm saying is that I end up being very confused by all of this and find myself hitting a brick wall working within the systems that we work in.
Thank you again. And actually, on a personal level, I'm really appreciating people's sort of honesty about the complexity, the difficulty with services. I think it's a really healthy part of this broader debate. To yourself.
I think I'm just somewhere between, because usually I'm trying to think who this diagnosis helps and what the consequences it may. Because in my practice, I have encountered a lot of young people below age of 24 when they have been given diagnosis where actually the brain development is up to age of 24. So actually, is this helpful for those young person where I know the research and evidence suggests on the follow-up 2 or 6 years, they do not meet criteria for the diagnosis? And I think secondly, in the older or people who are 30s, I would ask, actually, does it helps me or it helps them? Because they will be stigmatized, and lots of response from professionals, different professionals, are very range. Some are empathetic, some are really difficult to manage their own emotions, and they basically making a judgment. I am not going to see this person because there's nothing what I can do for them. And I think that's shame on the profession, if I may say.
Thank you. I'm going to come across this side and then to the back. Sorry, and yourselves. Yeah, great. Lots of hands. I'm just going to make one tiny comment, which was made by a very experienced consultant psychiatrist who left at the break, who will remain nameless. But I just wanted to put it out there, which was that we need the diagnosis, because if you're going to restrain someone or detain them under the Mental Health Act and do these very coercive practices, that label actually fulfills a function legally that the person can then challenge in that way. And it actually offers a protection for the patient in that regard. I'm not saying I agree with it. I won't name who it was, but I'm just putting it out there. I think first hand was there, and then there. Yeah, I'll come to all of you. We have. No, I'm all right. The exercise. I'm doing a half marathon in May.
Thank you. A lot of our colleagues don't use this diagnosis and are very proud of that, never using this diagnosis. I use it, and because sometimes it's helpful, but you need to explain to the person that this is possibly a very vague diagnosis, and people grow out of it, and there's different stages to it, but there's a help available. And I think that's incredibly important. And I think it's also important in terms of the systems. I talk about strictly dancing when I'm trying to explain it, that, you're a wonderful tango dancer, but maybe in the housing department, tango is not going to work. So we need something softer, like the Viennese waltz or something. And but I think we are notoriously good at harming this trauma people, whatever we call them, and make them absolutely horrendously regressed and much more riskier. So for us as a system, it's incredibly important. But also to try to protect them, but agree with the stigma of that. And that's really shameful of our wider system of healthcare.
Just going to go back to thoughts, so you have first, then yourself.
Thank you. Thank you for the afternoon. And I think I'm all for the diagnosis, because if there, not the diagnosis, but a diagnosis, because if there wasn't one, people wouldn't get to services like Dean's Cross. But I think my preference would be it was difficulties rather than disorder, personality difficulties, and perhaps more included the developmental component. I think if it was me having the diagnosis, I don't think I'd want the diagnosis, and I think it is stigmatized. And I think as a clinician, I come up with a whole thing in my head when I hear the words, even though I've worked in personality difficulties, and I'm really supportive and empathetic about them. But yeah, does it help me to be given that label? So,
Thank you. Just come to yourself and then across there.
Thank you again. This debate reminded me of another debate I've joined years back, which was done by Norman Sartorius and the DSM-5 team, when they were discussing about the schizophrenia, bipolar disorder, and schizoaffective disorder, and how to classify them and how to separate them from each other. So that was just before the DSM-5 came out. So they were thinking about a dimensional system instead of a categorical system, which couldn't easily take place in the DSM-5 yet. But I was just thinking if that could be possible. For example, we are writing a UPD and referring the patient to the psychologist, but actually this patient is quite avoidant and doesn't have that much impulsive features. So the psychologist is probably working with a name. We are referring a name instead of the patient. So I was wondering if in the future it will be possible working with the dimensions or the core features, as you said, like impulsivity, or like as in the case of anorexia nervosa, purging type or binging type. Maybe definitions, core definitions could be added there. This came to my mind.
Thank you. So I'm speaking largely in favor of the diagnosis of personality disorder. And I say that even though I feel quite ambivalent about it. I will often find myself almost apologizing to a patient as I'm giving them the diagnosis, saying, I'm sorry, this doesn't sound like a very nice phrase, but I just want to say, you know, like Richard, and like most people speaking here, I favor a kind of pragmatic approach. And like Tennyson, I actually don't find much to disagree with in what you're saying. I think it partly depends on the setting in which we practice. I think it's perhaps quite easy if one works exclusively perhaps in a third sector organization or in private practice to not use diagnosis and to say, well, you know, we've just got this frame and we're not going to use diagnosis. I think it's quite different if someone's in an inpatient setting and we need to be quite clear about what exactly the underlying problems are. And I think as doctors and as psychiatrists, we're always going to have a list of diagnoses, unless one says we should completely get rid of all diagnoses, which I think is quite an extreme position. So for me, being able to name a personality disorder actually holds it in equal esteem to other diagnoses. One can get into quite strange situations, including in, for instance, coroner's courts, where there's something of a sort of fiction that we were just treating this person for depression, but they had an extremely treatment-resistant depression, which, you know, and then one can get tied up in knots trying to explain why we didn't solely pursue the depression, as opposed to what is clear and obvious to everyone, which is that there were also these very important other considerations. And lastly, I would agree that formulation is in many ways superior, and I would always want to do both. But for me, I think we have to be clear of the utility of a diagnosis, especially on the more extreme end of presentations.
Thank you. It's sort of an open question for everyone. I'm interested in the notion of setting. On a personal level, I worked for 6 months as a trainee in a therapeutic community, which was extraordinary, very moving, very important for me. Very different understanding, suddenly changed jobs, completely different attitude and still within psychiatry. So maybe opening that even wider. If people have worked in other countries, different settings, does that change things? Was there a hand at the back? Yeah, two.
Oh, it's better than things to do. I was thinking for your question, but I have to be I feel like it was a huge bullshit to me for utilizing the terms because we call it stabilized chapters. I noticed that you give the reality. Your reality has become very healthy, and then we can carry all that. And I feel that age through personality disorder informs that kind of character. There's constant evolution which brings this this is where formulation where children they identify the traits. And then that ICD-11 the vision of the traits in terms of our understanding. So now it's become a category. So kind of being like the name of the street. So it's still a gray area, but I don't know, the concept of you constantly it's different in other countries where you call the state state.
Yeah, it's working. So I think I'm generally against the diagnosis, and something that I think is important in particularly EUPD or borderline personality disorder is about gender and how often it's a label that's given to women. And I can think of an example last week working the Newham home treatment team. A woman comes in who's extremely emotionally distressed. She's been sexually assaulted, went to the police who kind of softly coerced her not to press charges. You know, conviction rates aren't very good. She comes in extremely emotionally distressed. She saw the consultant a few days before she saw me and was given a diagnosis of a personality disorder, of emotionally unstable personality disorder. And I think that's something I've seen quite commonly happen, which I find extremely infuriating. And I think it's a way of kind of not really having to think too much about why somebody's distressed. And yeah, I think often personality disorders as well can be kind of given as a response to kind of extreme emotions we feel as psychiatrists and healthcare providers. So yeah, that's kind of an area of concern that I have with how it's used. And, you know, we live in a society, in a culture in which misogyny is very alive and well. And so we work in a healthcare system as well, which is a system, and it's alive and well in that as well. Yeah.
Thank you. Really important point. I've got sort of 4 or 5 hands up at the same time. We've only got 3 or 4 minutes. I'm just going to go in the order I sort of saw them, which was this side first and then that side. You two, and then I'll come across.
Just in the interest of time, I'll keep it really quick. I mean, loads of really great points. Yeah, I just wonder how much of the issues that are being raised are with our application of these diagnoses and or the actual problem with the diagnosis themselves. I'm no massive diagnosis fan. I don't think these are perfect. I don't think they're going to hold up in the next 20 years, and we're going to look at them, they're going to be unchanged. But it's really disheartening to see that we as a group of psychiatrists are giving the same diagnosis and patients are getting wildly different messages. There are some people who think that you should give meds. There are some people who think you shouldn't. Some people think this is an incurable disorder for the rest of your life. Some people see a trajectory with change and help. And the other main issue, I'm not sure if other people agree with this. I've not had anyone cry out of the room when I've said this might be PD. I've often had them go, wow, you seem to really understand me. It's sort of 1, 2, 3, 5 years down the line where what that means is that every door gets closed and that there's no help, and that, you know, they have an incredibly frustrating experience where they're stigmatized. Does that mean the diagnosis is wrong, or does that mean that we're just doing it really badly? Super thought.
Thank you. And because we're towards the end, I'm going to keep people to, that was great. So just shorter comments.
Yeah, just that I think the debate has morphed from what do we think about the diagnosis, and looking at the group of patients, to looking at ourselves. And I think that's probably a helpful evolution of the debate, because I think this debate to me is more about whether we feel clinically equipped to help these patients? How hopeful do we feel about our ability to help them? How empowered do we feel about our ability to help them? And I think that's quite varied. And we seem to locate a lot in psychologists. And I wonder why we don't think we can't be capable of thinking psychologically. And maybe that has been diminishing or decreased in our training and the emphasis of that. And maybe there can be a resurgence of that. So yeah, that's my thoughts.
Thank you. Comment there, and then as I come across, I'll ask for a last round of hands.
Yeah, I hope this won't open up a can of worms, but it's that whole trying to square the peg situation or whatever it is. I really enjoyed Dr. Bing's comment when he gave the formulation of the symptoms and you said, do you want the diagnosis? And they could option for that. And I'm wondering if we're kind of debating an all or nothing situation where we give the diagnosis or we don't give the diagnosis. And I'm wondering, oh, wouldn't it be have a nice middle ground where we can have that option, the patient can opt for the diagnosis, but in order for us as professionals and for the protection and all the benefits that Hugh mentioned about coming to coroner's court, et cetera, have a diagnosis for us, but the patient can opt in or out for it, or would that just make things really messy? But then it might straddle both worlds where the person can be a whole person and not just a diagnosis, whilst we can still talk together in diagnostic terms.
Interesting, thank you. I'm going to come across to the 2 points here and just hands up for a last round of comments.
Hi, Ben Wright. I'm a practicing medical psychotherapist. I mean, I've heard the panel say that essentially the diagnosis hasn't. Well, firstly, I should say that I'm a firm believer in diagnosis generally and not in the use of personality disorders as a label. For my own clinical practice, I don't really help. It informs me prepare a psychologically informed formulation of my work with that person, nor does it help my therapeutic relationship with the people that I'm working with. And I'm hearing the panel say essentially that it hasn't really informed research, and it hasn't really directed treatment in terms of the finer details of what we actually do with the person in the room, rather than putting them into a large category. Just to finish with my own clinical experience that was very formative in my understanding, is I saw a patient who really fulfilled all the diagnostic criteria for narcissistic personality disorder. It was very, very difficult to be within the room, caused lots of problems in the system, and really, gave me a strong professional urge to say, so much that I can't really help you, but I didn't. Because we identified from a psychological formulation that the onset of his difficulties was based on a whole level of low-level trauma. Through quite a difficult psychological process, we treated that trauma and the narcissistic structures disappeared. Now, I do think there was an underlying vulnerability that made him susceptible to developing those processes, but that was really a point in his life where if we'd gone down the path of putting him into the category of personality disorder, he wouldn't have got care, he wouldn't have got treatment, and he'd have been destined to remain with his significant interpersonal difficulties for the next 20, 30, 40 years. By targeting the underlying psychological processes, I was able to successfully enable his recovery, to change him into a person that actually he was quite pleasant to be with by the end of treatment. And that was not the clinical presentation at the start. So I'm a strong believer in diagnosis. Panic disorder, for example, gives us a direction to an effective targeted treatment. Generalized anxiety disorder, the same. Social phobia, the same. When I started in psychiatry, none of those treatments were available. So we did have a clear categorization that led to a research that led to effective intervention. We haven't seen that in personality disorder. My final point is the reason for that is this. If we hypothesize that there are 7 substance systems in the brain that direct our whole being, which there clearly are a lot more, but even if there were only 7, the number of permutations and combinations of the presence or absence of those functioning systems is about 5,000. That's why this approach hasn't worked, because we're trying to eat the elephant in one mouthful, rather than approaching it from the other end and trying to look at the subsystems and psychological processes and targeting those. And trauma provides one of the best way forwards for doing that.
One point there.
Yeah, I was just going to say that I was quite
I kind of smiled and was bemused even at the title. I thought it was incredibly myopic and fantastical to even entertain the idea. But especially when you look globally at how mental illness gets treated in insurance-based systems around the world, I thought it was really nice that that could even be put forward as an idea. And I do really agree with the lady's point at the back about how in this country we reformulate the terms almost pedantically preoccupied with these who might offend the patient. I'm not really going to mention whether or not I'm for or against the diagnosis. I think in a way it's been well people have argued both sides quite extensively, but I do always think about people are saying about the research that medication doesn't work for personality disorders, and that actually there is an evidence base for DBT, personality disorders, and MBT. And I just kind of think, well, where does all that research go if we say that personality disorders don't exist? I just find that really incredibly dismissive, and I think there is actually a lot of research about what does and doesn't work for personality disorders. People really need to hold on to. But yeah, I think it's myopic and fantastical, actually, the title even in and of itself.
Thank you. We probably have time for one more comment, and then we'll have 2 minutes each. Any others?
I was just going to say that obviously there's always debate about the validity and reliability and usefulness of diagnosis. So I was just wondering what's changed with ICD-11 and if that has made it better or worse for people with personality disorders. One of the issues was the introduction of the category of personality difficulty. And that doesn't sit, I think, in the same section with personality disorders. However, I don't know how that is a legal diagnosis that could be used for sectioning or terms like that. So in that sense, I think this blurs the boundaries between diagnosis or non-diagnosis of personality disorder in ICD-11 and may lead to a very different approach. I don't know, I'm just having some thoughts.
I'm in this great position where people often make eye contact with me as though I have any answers at all. So yeah, I'll just sort of nod and smile, but I don't have any answers. I think we have to stop it there just for timekeeping. We'll come back to our speakers. I want to thank you all. It's a slightly unusual format for the Barts debate. It was something that was designed to provoke some thought and discussion as colleagues. And I think we've touched on a huge range of things, from resource issues to training to the philosophy and nosology, the whole nature of categories. So thank you all for taking part. I'll agree it was a bit sort of binary and the nature of these debates. So if we could get our two people back up for 2 minutes closing, then we'll do the final vote and then some closing comments. So I think it's Richard first. That's how it should be done? I'll give you your 2 minutes to win people over.
Yes, thank you very much. And yeah, thanks for all the additional comments and arguments showing the problems of personality disorder as a diagnosis. What I'm suggesting is that we have an alternative way of looking at it, but it does take some creation to make it work and work as a system. So we have to do some work and create this dimensional approach that is a better way of helping individuals understand each other and a better way of targeting research to support individuals. And that we have that ability as humans to do that, and we shouldn't just give in to the system because the system is us.
Thank you. Tennyson, last chance.
Points made by the room are really useful. So just to point that actually at times we make an inaccurate diagnosis. So I think what I'm arguing for is an accuracy in an attempt at making a diagnosis, and that there is a role for defining this it. It isn't it, and I think Richard's point that it's an ontological issue. What is personality? What is personality? But I don't think we should, because we don't know what it is, just say, well, let's throw the term out. So that's my main argument. Just also to say that the evidence shows that the diagnosis can be made reliably in adolescence, and that diagnosis continues into maturity. And the evidence also shows that interventions at an early age make a difference. I think that's an argument for retaining the diagnosis.
Thank you. I'm just going to click up again the final slide. Hang on, sorry, apologies. That's actually the feedback slide. It's the not done well, have I? If anyone can help me, I'm very open to being helped with this. Where Sharman is there? Down the bottom. Edge browser. Why am I just not completing that?
Blues. Are we doing the voting?
Ah, okay, down there. Oh, sorry. Right, I'm with you. Thank you very much. That was
If you click on this and share link.
okay.
Yeah.
Great. Thank you very much, Ben. So just a minute to complete that. So I got 15 versus 45. This is also a marker of how many people are still here. We use it surreptitiously to monitor your GCS. So yeah, I had it about 3-1. So if it gets anything a bit closer than that, then we're moving away from diagnosis of personality disorder. Give me a wave if you've done it, or actually other way, better way around. Give me a wave if you need more time to complete it. Yeah, just doing it there. Crucial last votes. It's looking closer than it was. Is that fair? My technical abilities this afternoon have not been at their best. But 15:45. It's probably had 3 or 4 people move away from diagnosis is what it feels like to me, from 15:45 to 18:40. Okay, hands up if you need more time. Otherwise, I think we're going to call it quits on that. Yeah, I think we're going to close it there with what it looks like about 3 or 4 people moving across and some people voting who hadn't voted before is my best guess. So close. Thank you very much for engaging with that. There is feedback at the end, which I'll just put up. We've got a lovely challenge for Scott to somehow bring together, summarize, reflect on an entire afternoon. Thank you for doing that.
Yes, there was a bit of movement. I think it went 75% originally disagreed down to 69%. So welcome. Move some people. You know, how can I sort of sum that up? That was a fantastic afternoon, really lively, great. I mean, what was fantastic was the amount of involvement and participation. And when we're sat in a lecture theatre, it's often really difficult to get people involved, but there were so many comments and every single person that commented, you know, made a really valid and important point. I think for me, the takeaway is that this reminds me what psychiatry is really all about. This is really sort of striking because a diagnosis, you know, or diagnostic systems are merely hypotheses, you know, and once we kind of use them and put them out in the world, I think Richard made the point, communities use them, but actually lots of other people use them, including when our patients pitch up in places like A&E and they see a diagnosis, and that can be really harmful because of the diagnostic overshadowing. So as psychiatrists, you know, what I'm hearing is that we want to use a diagnosis, but we want to make sure that it's used well. And what I'm also hearing really strongly today is, you know, the ability to be uncertain and not to be absolutely kind of, you know, have things cast in stone, which once upon a time, I remember when I first went to psychiatry, that's what people used to say. That's what made us psychiatrists, made us different from other kinds of doctors, that we could tolerate uncertainty. And as time has gone on, it's become much, much harder to be uncertain and to be openly uncertain and to be creatively uncertain because resources are so limited now. You know, the systems that we work in, I was shocked, you know, to hear of a CMHT working without any psychologists. You know, we're the ones left behind. Well, in primary care, colleagues are left seeing the patients that they can't get us to see, or the patients that we're forced to discharge. The systems that for a decade or more have been saying that all interventions should be brief. The loss of psychodynamic psychotherapy in mental health care, which used to be, you know, fundamental, is coming back, I'm pleased to say. But, you know, the kind of antithesis of good care for people with personality disorder is brief care. You know, if you've got a system, your brain is kind of wired to be, to react really strongly to threat and to the threat of abandonment and rejection. And what we do is we reward you for therapeutic progress by re-traumatizing you. But we're told that we have to do that. And as psychiatrists, other professions come and go, they pick and choose, and we're there. And I think, you know, this is what reminds me how brilliant it is to be a psychiatrist, that we can do that job and continue to find it rewarding and continue to fight for our patients. So that's what I take away from today. And thank you so much for inviting me.
So I want to extend that thanks back, because personally, I think it makes a huge difference to have speakers in person. It's not always possible, but to have two speakers who come all the way from Plymouth and Sheffield for this afternoon, I think is a real, well, I think we should be very grateful for that and for the thoughts and richness of the thinking they brought. I think we will all be following your research, Scott, and looking out for it. It sounds very exciting. So you can always come back and update us. But I think maybe a round of applause for their efforts. And a big thank you to Tennyson for organising, and Cam in absentia. It's either his wife's birthday, I think. It's a very good reason he couldn't be here, but he sends lots of love and sorry he couldn't make it. So thanks, Tennyson, for organising. I think we're getting away 15 minutes early, which is we'll do it. Thanks, Tennyson.